Good morning, good afternoon, and good evening, everybody. I am Dr. Isha Goyal. I work as surveillance officer in World Health Organization and working in the field of immunization since 7 years. So recently, in this 2023, I had a lot of measles outbreaks in my district. And what we have done to control the measles outbreak is we have prepared a line list and we have a system of listing all the cases. So in India, let me explain the some basics. Village is the lowest point. Multiple villages constitute a subcenter, and multiple subcenters constitute a block. So block is the unit where we flag the outbreak, and as soon as the outbreak is flagged, we do a preliminary investigation there to find out more cases. And if we found more cases there, then we do a detailed investigation there in which we go house to house to find fever rash cases currently or in the previous 3 months. This activity is done and supervised with the help of World Health Organization. So we try to maintain the quality, but the improvement is required in this only, that the government officers and the government staff should be sensitized to this level that they can do without the support of WHO. This is the improvement point which I need in my district. And the one thing which I noticed is, which after analyzing the data, that 90% of the cases were in a single community, and most of them were unimmunized. And I have been listening the HPV vaccination also, and I have worked in introduction of the new vaccines in my country. And in multiple scenarios, there is same community who resist for vaccines every time. So I have listened the previous session also that people have involved the religious leaders, community leaders, but that is my concern, that in my district I have faced this situation that every time the same community and same people are there who refuse for vaccination, be it polio vaccination, be it measles vaccination, be it COVID vaccination, or maybe in future when we will launch HPV vaccine in India. So this is my concern, that whenever we find or design some strategy at the local level, that is good, but at the global level, we also had to find out that whether the same communities or the same population are refusing the vaccines every time, because it's a need of our to take action at the global level also along with the local level. And regarding the measles outbreak, I want to add one more thing, that after the measles outbreak is identified in any area, we try to convince the people to get their children vaccinated with the MR vaccine, which is in the universal immunization program in Government of India. And we successed in many of the areas, but only up to 60 to 70% children were immunized even after the outbreak. The 30 to 40% children still we missed, and they are not ready to get their children vaccinated even after the all the mobilization activity. So that is my concern and the challenge which I am facing, that after many efforts, after involving the community leaders, even after having the special immunization weeks in my country, these certain people are there who are not ready to get their children vaccinated at any cost. So I am associated with TGLF also since 3 years, and I have continuously been listening to these sessions, and demand creation issue is always there. So at the local level, I have been listening that everybody is involving the community leader or religious leaders. But what we have done at the global level for this situation, and have we analyzed the data for all the countries, but that there is a same population which refuse vaccine every time, or is it a different situation every time? So I need certain means light on that topic, and that's from my side, that in most of the cases we are able to control the outbreaks, but still there is a lot of scope of improvement for the coverage of the measles containing vaccine, so that there will be no outbreak in the future.
Thank you very much indeed, Isha Goyal. So we're going to go to Laura Shimp at some point for feedback, but let's now, and a very clear description of the challenges that you face. Charlotte, who shall we hear from next about this topic of measles outbreaks? We're just getting into it. And Laura says, let's see, for this session on measles, she'd love to hear examples from participants on how you are ensuring that individuals have a record of both doses of measles vaccines that they've received. Often vaccination cards are not emphasized or made available long-term, particularly for second dose. Measles campaigns also have not often given cards to those vaccinated. So we'd love to hear if you have specific examples about that. Otherwise, back to you, Charlotte. Who shall we hear from next?
Yes, brother, I was inviting Caroline Akoshile to speak, to share experience, because we already received that, but we had some two hands that I'm also inviting to unmute.
All right.
So,
all right, and that is Joseph Abubakar Koloko. Mudassir Abdullahi is the first one to unmute. And again, for our guests of honor, please be ready. You've been invited to our Zoom studio in order to speak. So please be ready if we call on you to share. Mudassir Abdullahi, please do introduce yourself and tell us what you did to respond to a measles outbreak. Again, this is not about expressing an opinion on the topic or discussing theory or generalities. This is specifically about things you have done or carried out. Mudassir, tell us about, first of all, who you are and what you do.
Hello.
Yes.
I work with Kano State Hospital Management Board, Nigeria. I'm a member of State Routine Immunization Coordination Center. Measles is one of the diseases that are very common in our country, because for one reason or the other, mothers don't usually access the vaccination sometimes due to one reason or the other. But whenever
Mudassir Abdullahi, when you say that, is that based on your personal experience? Are you a vaccinator engaging with their caregivers, or how do you know that? Or why do you think that mothers do not?
Mothers, they start the vaccination, they come for BCG, Penta 1, Penta 2, they have that.
I'm asking how you know that.
Through our activities,
okay,
when we are reviewing the data.
I see, but does
in my count,
yeah. So the data may show you that there missed vaccination for measles, but how does it tell you that about caregivers' attitudes and behaviors?
Well, I can't tell you. The network is fluctuating. It's not stable. Hello?
Yes, no, we hear you loud and clear. So what have you actually done or carried out to respond to a measles outbreak?
What we did to map out the settlement where the cases come, and a response team was deployed there to assess the status of the immunization of the children. Through that, we came to understand that most of them were missed their measles vaccinations. So as a result of that, an engagement was conducted with the caregivers where an awareness was raised, and most of the children that were not infected there, and then a vaccination team also set in and ensure that all the children that were not infected were vaccinated, and advice, a kind of health education was given to the mothers in order to see that when they have the first dose of measles vaccination at 9 months, they also come back to the facility to have a second dose of the measles at 15 months. As a result of that, most of those settlements that reported the outbreak in the previous year, there was not such cases in those areas.
All right, thank you very much, Mudassir Abdullahi. All right, let's now go to, I see again in our Zoom studio, and we apologize. We appreciate actually that so many people take the time to respond, to share their experience. Again, we'll be honoring this by publishing a publication dedicated to the experiences that you shared. For now, Charlotte, who shall we hear from next after Mudassir Abdullahi?
I see Dr.
Deepanjali?
Bala and Deepanjali. Yeah, Reda.
All right, let's go to Deepanjali Shretha. Apologies for mispronouncing your name. Deepanjali, a warm welcome to you. Tell us who you are, what you do, and then again, we're interested in your actual experience, what you did to respond to a measles outbreak, as you can see. And we did ask even more specific questions around vaccine wastage, around the specifics of responding to an outbreak, on using data in measles outbreak response, improving second dose coverage, or integrated health campaigns. Tell us, first introduce yourself, and then tell us what is this experience that you would like to share.
Good afternoon, Reda, and everyone who has attended this function. I would like to thank, I'm Deepanjali Shrestha from Uganda. I am originally from Nepal. I have experience of measles outbreak. So what would have been better is that we should have a training for preparedness plan for the vaccination for measles. And if we have training for preparedness to overcome for the outbreak, then it would be better. And for the improvement. For the improvement, what I have done is we had a meeting for the plan to organize the administration of the vaccine, and then we plan to procure vaccines which are required for the beneficiaries, and supplies, and storing and maintaining cold chain facilities before starting the administration, and then appointing skillful nurses and preparing more vaccine administration stations, what was done at the time of measles outbreak from myself. And then the challenging thing what I faced and what my team faced is vaccine availability according to the demand of the vaccine. So we are not able to receive the vaccines on time, so we have to postpone for the vaccination program, and then again we have to call them, and it took a lot of pressure for all the team. So the most challenging thing is availability of the vaccine. And another thing is because of not receiving the vaccination card, we have to give the vaccines to all those who has not received from the government side. Thank you.
Thank you very much indeed, Deepanjali. A very clear description of your experience, and very specifically on what you could have done better, what's been most helpful, and what are the challenges that you face now. Charlotte, is it Dr. Bala Ganesakumar who is next?
Yeah.
Yes,
Yeah.
Okay, wonderful.
Yeah, I'm.
Yep.
Yeah, thank you, Reda, and thank you, Charlotte. I am Dr. Bala Ganesh Kumar, Surveillance Medical Officer, WHO from India, and the southern part of India, that is South Province of India, Kanyakumari district. Recently, in the July, first week of July, I had a call from one of the very high priority institution, a medical college, nearby medical college. A pediatrician called me, and he told me about there's one case of fever with rash in my hospital admitted. And the sibling of the child also had the same history 10 days back. So he notified that case to me. And as being a technical expert on this, I immediately asked them to take the appropriate sample. There was only within 7 days of onset of rash. So I asked them to confirm the diagnosis, to take the samples, both virological and serological samples. And samples were sent to the WHO authorized lab for confirmation. At the same time, I informed the same to the local health authorities to form the epidemic response team. And at the district level, at the block level, taluka level, they formed the epidemic response team was created. And myself being a member of that, I trained all those people who are going to do that field activity regarding how should they approach that type of query suspected outbreak in that place. And we trained all of them, and we started our initial house-to-house survey. The child is being 10 years old, so we started with the house-to-house survey. As well as the same time, we had the survey at the child was studying which school. Also, we did the same survey, and we had take up the line list of all the cases who had the history of line list, all the history of fever with rash for the past 90 days, and we created the line list. And among them, we took them samples for around 20, whoever had the fever with rashes for the last 28 days, we took the samples, appropriate samples for first recent 7 days cases, we took the virological and serological, and more than 7 days to 28 days cases, we took only the serological samples, and the same appropriate samples were sent to the authorized lab also. Then what we did is we analyzed, enumerated all the below less than 5 years children in that households and that schools, and we ensured their vaccination status, whether they have been vaccinated with MR2 doses or whether they have missed any of the single doses. We ensured it. At the same time, we are all the fever with the rashes cases, we give prophylactic vitamin A also. We have 2 doses we gave them, and then whomever we identified those children who are not vaccinated or under immunized or who have the immunity gap. Those children, for them, we conducted a special catch-up campaign to cover that immunity gap. And after that also, we kept that villages under vigil for the coming 90 days. So my problem here is, if we are going to take the line listing of difficulty, what I felt is, if you take for the history of fever with rashes for the last 90 days, many of the people have had the history, but many of the people are not even there itself. They have migrated, or they have, for their work travel, they have traveled to some other, not migrated, they have traveled to some other places. So whether we should track them also because they have traveled to many places. We are tracking the viral transmission among this community, and we are tracking the travel details of the positive cases only, but all the other cases we have missed. They had more than 50 days, 60 days, 70 days before they had the fever with the rashes cases, they have traveled to some other places. So how to track them also? Is there any protocol regarding that? That also I want to know about that. Thank you. This is my experience regarding a measles outbreak investigation in my area. Thank you all. Thank you.
Thank you very much indeed, Dr. Bala. Next, we'll go to Caroline Akosile, and then we'll turn to our guides on the side. I realize it makes things more difficult for the guides to have many different stories. Each one would warrant an extended discussion. But remember that this session is followed by networking. So if you'd like to follow up with individual meetings to go further, we hope to leave you thirsting for more. Caroline Akosile, we have... Yes. You shared from Sokoto State, Nigeria, a story about partnering with stakeholders to improve the uptake of measles vaccines in the communities. We'd love to hear it directly from you. Go ahead, Caroline.
All right. Good afternoon, good evening, and morning, everyone. My name is Caroline Akoshile. I'm retired. I worked for UNICEF for 20 years, and I've had a lot of experiences on vaccination, especially measles vaccination. And basically, I would say what's most important that I learned or that I experienced on the field, it's the preparedness and the actual response. We needed to prepare, and I worked as a communication for development specialist. So we needed to really talk to the communities on how important the measles vaccine is. And then when we got there, we needed to really work with the stakeholders, like the policy makers, the community leaders, and so on. And then work also with our logistics people to give the children the vaccines during that time.
So now, Caroline, I'm going to ask you a question already. When you say we worked with the stakeholders from policymakers to caregivers, that's very general. It doesn't tell me what you actually did to do this work. Can you give me an example of something that you did, perhaps for the first time in this context, because that you had not done before? Can you think of an example like that, or just illustrate what you mean by working with stakeholders?
We worked with them in the sense that we had meetings with them, sensitization meetings with the stakeholders. We had the meetings, and especially also with like the heads of communities. And then we also had some house-to-house talk with the parents, with the caregivers, to explain to them why why we were having the measles campaign at that time. So we needed to tell them that they needed to immunize their children against measles. So those were the type of meetings that we had, or activities that we had with the stakeholders. So because you cannot achieve this alone, you needed some other people to work with you. Right. So, and then what we will have done differently if I was on the field now, which really I'm still on the field, we will have had some maybe outreaches, because now when I'm on the field now, I find out that children who came for MC1, not all of them are coming for MC2. Looking at the registers at the health centers, we needed to have a line listing of the children who are supposed to come, and then maybe go to their houses and make sure that they come for the MC2. And then what are the most difficult challenges that people face on the field now is, I would say, funding. Yes, because they need to go to the field, they need to go to all those areas, communities, to make sure that these parents bring their children for the MC2 especially. So these are my experiences on the field. So we need to prepare, we need to also respond at the right time to make sure that the children get the measles vaccine. And then when they're having campaign like a catch-up and so on, especially in Nigeria, it's not all the states that are involved. They do it in batches. So some states were not involved, and there is a cohort of children who will be left out in those states. So we need to work more with those communities in those states to make sure that the vaccines are available, the children are given the vaccines, and then the workers too are given the enabling environment and the enablement to go and give them the vaccines, and also fish the children out to give them the vaccines.
Thank you very much
so
indeed.
Do you have another question for me, Reda?
Let's find out. So I'd like to actually turn to our guides on the side. So this time I'm going to start with Dr. François Gass, and to ask him for his three main takeaways from the discussions so far. So either comments that he'd like to highlight, specific feedback, or questions that he would want to ask if we had the time to take the discussion further. François, if you are able to unmute at this point. Otherwise, let's go to Laura with the same challenging ask. And Laura, there's a lot of complexity to unravel. Can you help us unravel this discussion and go away with three takeaways? Your top really points that you feel are really important for everyone to hear, that is likely to be helpful to the practitioners who've been sharing their experiences.
Yes, thanks so much. Thanks for the contributions, and thanks for the comments in the chat as well. Sorry, I'm not able to respond to every one of them because they come in fast. Right. But very important. Three key things that I think we've heard. One is using data to really help us also identify where we have missed infants or younger children who may have received one dose of measles but not two doses of measles. So how do we really look at the data available, such as in registers or from cards and other things, to really be able to identify those who need the vaccine, and then encourage not only that the community members, religious leaders, and others encourage them to come back for services, but that the health workers welcome them back. And particularly for measles, similar to what we saw for COVID, it's so infectious. If you are exposed and you're not vaccinated, you will most likely get sick. So it's important to really help emphasize the importance of those two doses of measles protection and be able to help health workers provide that service as well. Some people noted the issues with distances for vaccination sites, or, we know we have this issue with 5-dose and 10-dose measles vaccines where health workers sometimes don't want to open the vial if there's only 1 or 2 people. So really working with the health system also to address these problems, to to better communicate how to get, not to turn people away. What are the best way to organize these services so that we get people vaccinated, don't turn them away for these various reasons. And then I think being able, like people have described as a third thing, to take, not when we have an outbreak and we do campaigns, that campaign shouldn't just stop the day we're doing vaccination. We need to really insist with the vaccination teams, with those who are helping provide resources, that we need to follow up by using data to track where we've missed infants or where we need to find those that may not have come during the campaign. So really not just planning for a 1 week, but planning for a 4 week, so that you also follow up with those communities that have been missed and can help the health workers continue to provide that service, not just during that campaign day. Thanks so much. Great contributions.
Thank you, Laura. Now, we do have Tongwa Gulit Nkani, who's asked, he says, I'm a guest of honor and I haven't been able to speak. So perhaps, Charlotte, we can make an exception. We did try to reach to Tongwa earlier to hear from him. He'll have to unmute, of course, and is not done so yet. All right. So okay, I think this is what happened last time. Yes.
We also had Kamran Khan from Pakistan, who was already unmuted, one of the contributors and also a guest of honor.
Yes.
So had his contribution experience shared. I think it was about vaccine wastage.
All right. And for Tongwa, we're very sorry. And for you and other guests of honor who did not get to speak, in this case, it does seem to be a technical problem on your side. Kamran Khan, you'll be our last speaker, as we do have one more topic in this plenary before we shift to zero-dose children in urban settings. Kamran Khan, what would you like to share about what you did to respond to a measles outbreak?
Yes, thank you. My message will be very, very short. My name is Dr. Kamran Khan from Pakistan. I have worked in immunization program as a district communication officer. I want to share about the nationwide campaign launch in 2021, in which I was working as in one of the district as in District Charsadda in Khyber Pakhtunkhwa as a district communication officer. Just three things I want to share which have a very good impact on our campaign. Before starting a campaign, apart from micro planning, training, and other type of activity, we have given special focus to the social mobilization. Like one thing we have done, the advocacy, we have vaccinated the children of policy maker in front of media, and then we send those pictures on medias for mass awareness that the policy makers are vaccinating their kids, so to build community trust on vaccination. Number two, as the age bracket for this nationwide campaign was from 9 months to 15 years. So our 70% target was in school. So we have properly mapped all the school. We have done awareness session in the school with teacher and student, and we also send a consent form from school to the parent. And those parents who were not willing to vaccinate their children, we call them to the school, which we directly meet them and done a session and try to convince them. Majority of them were convinced, and we vaccinated more than 95% children in that campaign. So this was my some few better planning, or you can say a better some lesson learned. Apart from this, we have faced AFI, adverse event following immunization, and when it goes on media, so it also affects our campaign. For this, we have already mapped the media channel, engaged them, and we have proper media cell. Before sending any news on the media, it was properly filtered, it was properly corrected, and then shared on the media. Thank you.
Thank you very much indeed, Kamran Khan. Lots of great comments and discussion dialogue going on in the chat in our Zoom studio, but also, all right, some of you are still stuck on YouTube. Please check the emails that you received. There's also lively discussion here on the main stage of the conference platform. Now, we invite you, remember, this is only the beginning of a dialogue. Teach to Reach is an ongoing, continuous learning conversation.